Okay, this is the final week of the study of acids and bases and fluids and electrolytes. We haven't done the fluid and electrolyte lecture yet. We're going to do it tomorrow, but I wanted to record this for you guys so that you could watch it since we're kind of out of lecture time due to the fact that we lost the lecture for the PCC in service, and we also lost a day due to the bomb scare. Anyway, here we go. This is kind of an extra lecture that I throw in, it's basically a clinical conference. Now, I know that we're in some ways not supposed to teach clinical things in A&P. However, when I went around the room at the beginning of the term and I asked, what did each of you want to be? Not a single one of you said, oh, I want to grow up to be an anatomist, or I want to grow up to be a physiologist. You all said, I'd like to be a nurse or a dental hygienist or an x-ray technician or an EMT, paramedic, and so forth and so on. So I try to base my teaching on that. Obviously, I came from a clinical field of general surgery and vascular surgery and trauma surgery, but I just think that this is important stuff, and I think the way you learn A&P the best is by learning it from a point of view that comes from really where you're at. So we're going to do a little clinical stuff today, and you'll be glad to know that I'm sitting in my motorhome because we just got back from Newport from the weekend, and the dog is ready to be home, and he's in the side, and my wife's inside, and I'm enjoying a glass of wine. I've finished it, and so I'm going to talk to you about this clinical conference. And I put this together two or 3 years ago, and I think it will help you kind of put the whole fluid and electrolyte thing together. I could be wrong, but I think it'll work. So this is a story about water, electrolyte, and acid-base balance, and it really has nothing to do with anatomy and physiology. Or does it? I went down to OMSI with my granddaughter a couple of years ago, and there was a thing about medical things, and there was a game called You're In. You're in the game. So here we go. And here's the way you might want to think about this a little bit. Most people go their whole life, and they never give a thought to their fluids and electrolytes. They remain normal. And I'll bet none of you have been in fluid and electrolyte crisis in your life. We get up every morning, we sweat, we pee, we drink, we eat, we shake the salt shaker, we run fevers, we have illnesses, we run marathons, we vomit, and yet we never have a problem with our fluids and electrolytes. And if you think about it, that's pretty amazing. And the reason is we have these wonderful control systems that we've been talking about for this last few weeks and months. Both our respiratory system, which can control our PCO2 levels and thus control our pH, and we have our urinary system, which can control all of our fluids and electrolytes, including our acid-base balance. So that's a pretty amazing thing to think about, I think, and I am always thankful for it because it's bailed me out a few times in my life. Now, fluid morning rounds, every morning you go around and see all your patients, and fluids and electrolytes are a very big deal. We spend a lot of time every morning when we go around to see the patients talking about their inputs, their outputs, and what their SMA6 is, and how everything's working out. And I think the whole reason for that is because modern medicine is so amazing. It has become so invasive, and we can take away so many things from patients that we can take away basically all of a patient's natural control mechanisms. The diseases that we're now able to treat are so extensive that the disease alone removes all of these corrective mechanisms in the patient, at least for the short term. So if the patient is without all of these corrective mechanisms, then we as physicians and healthcare workers sort of have to step up and make sure we're not screwing them up too bad. That's kind of the way I look at it. Input and output is a big deal. The I and O is very important. Most every patient in the hospital, especially if they have an IV, a needle in their arm, especially if they have an NG tube in their nose, especially if they're not able to eat, drink, and do all the normal things, is on I&O, which means the nurses and everybody associated with the patient in direct patient care is involved in monitoring the input and the output. Now, in order to monitor input and output, we got to think about what are we talking about? What are the sources of input? What are the ways that fluids and electrolytes are put into the patient? And so I'm not sitting here talking to a bunch of you, but if I was to ask you for a list, most of you would come up with most of the things that are on this list. Sometimes we let patients eat and drink. Most of the time when we're dealing with a fluid and electrolyte crisis patient, we don't let them eat. We don't let them drink. And that's basically so we can control everything that goes in and everything that comes out. Now, it's not that specifically, it's the fact that usually they're not able to eat or they're not able to drink. And therefore, we have to kind of help them down the line. Most people are NPO. NPO means nothing per os, nothing per mouth. And the bottom line in these modern days is if you're well enough to eat, you're probably well enough to go home. And so very few people that are actually in the hospital, at least on my service, general surgery, once they could eat, boy, they were on their way to the house in general. This is a big deal, is ice. Patients would beg and beg and beg me for some ice because they said, oh, Dr. Sessions, this tube in my nose is bugging me and I feel so dry and I'm so thirsty. Please let me just have a little bit of ice. And I would say, okay, here's the problem. They would then ask the nurses for big glasses of ice, big jars of ice, and they would eat the whole thing down. And next thing you know, they had 2,000 cc's of oral intake of water. Now, understand that that's water with no electrolytes in it, so that can be a really huge problem. And so I had to be the bad guy, and I always had to restrict exactly how much they had. And usually I would restrict it to something like 30 cc's Q2 hours, something like that. And I told the nurses they just had to be a bad guy about it because these patients were going to get themselves into trouble if they drank too much free water. Blood, packed cells, plasma, those are also sources of input into the patient. IV fluids, as illustrated here, is obviously a big source of input into patients. On the previous slide, I think showed dextrose 5%. That's just sugar and water. This one is lactated ringers. Lactated ringers is a solution that I think, have talked about, but basically it means that the IV fluid is almost like a normal SMA6. You can't quite read these numbers here, but it's basically just the same sort of electrolyte concentrations as a patient has in their blood. My first experience with Ringer's lactate was doing frog labs when I was in high school biology, and you'd take this frog muscle and you'd put some twitches on it and you'd make it contract, and you always kept dripping Ringer's lactate over it to keep the muscle moist, and you were basically bathing it in a solution that was the same as they would normally be bathed in Ringer's lactate. Quick little talk about IV fluids. I believe you only need to know 3 IV fluids to understand everything. There's a lot more than that, but they can all be calculated from those 2. And so those 3 big IV fluids are one is called D5W, that's dextrose 5% in water. The second one is Ringer's lactate that I just mentioned. and the third one is normal saline. Normal saline is just salt and water. So let's go through them one by one real quickly. D5W, the way you make it is you put 50 grams of dextrose in a liter of fluid, and you have a liter of D5W. Notice that it has no sodium, no chloride, no potassium, no calcium, no nothing. It just has 50 grams of sugar. Now, are you going to get fat on this diet of D5W? Well, not really, because 50 grams of sugar is 50 grams of carbos, and you know from the last chapter that a carbohydrate, has 4 kilocalories per gram. So you're talking 200 grams per liter of this stuff. So if you had normal amount of fluid, which is about 125 an hour, which is 3 liters a day, that patient would be getting a grand total of 600 calories. Nobody's going to get fat on 600 calories a day. The problem with D5W is that it doesn't have any sodium and doesn't have any chloride. So if patients only get D5W, this tends to just run fluid, water through them. They're not getting any electrolytes. Pretty soon they're going to run low on sodium. They're going to run low on chloride. They're going to run low on potassium. And so you always have to beware. The problem with D5W is almost every medicine that the pharmacists prepare for us down in the pharmacy. Say the patient's going to get a gram of penicillin 4 times a day. So they take and put the penicillin in a small IV bag. They add some D5W to it, maybe 200 cc's of IV fluid just to dissolve it, and then they send it up to the ward in this little pack. And this patient gets that pack of penicillin hooked up into their IV. But if you're getting penicillin and you're getting gentamicin and you're getting 3 other medicines through as a add-on or a piggyback, we call them, you can get an awful lot of D5W. And D5W, like I said, can get you into trouble because there are no electrolytes in it. We'll come back to that. Normal saline is the second one of the big 3. Normal saline is 0.9% NaCl, which means it's got about 154 milliequivalents of sodium in it, 154 milliequivalents of chloride. It's nothing but salt and water, normal saline. Now, what that means is that it has an osmolality of 308 because there's 154 milliequivalents of sodium, 154 milliequivalents of chloride. And so it's pretty close to normal osmotic concentration, which is what you want. Just as a aside, down there at the bottom, I said that half normal saline, which is 0.45%, half of 0.9 up there, it only has 77 milliequivalents of sodium and chloride. And so oftentimes we use that as an IV fluid because that's enough sodium and chloride for your body to hang on to. We also add 20 milliequivalents of KCl to it so that you have some potassium coming into your body as well. Because if you're NPO and all you're getting is IV fluid and you're not getting any potassium at all, you're going to gradually go down in potassium. The third one, as I said, is Ringer's lactate. Ringer's lactate is pretty close to normal plasma concentration of all the electrolytes. So if you look on the bag, it says it has 130 milliequivalents of sodium. It has 4 milliequivalents of potassium. Remember, that's normal potassium level. 3 milliequivalents of calcium. That's a little bit low, but yet it's still some calcium. 109 of chloride. Remember that chloride is normally about 100. And 28 milliequivalents of sodium lactate. Now, sodium lactate obviously has 28 milliequivalents of sodium and 28 milliequivalents of lactate. And lactate is basically your bicarb. So you're basically getting your bicarb in the form of lactate, and remember that normal bicarb is about 24 on our normal electrolyte level. So what's so cool about these big 3 IV fluids is that they're all isotonic. And believe me, if you're a patient and you have an IV out in your hand or out in your arm somewhere, you want to have isotonic IV fluid running into it. If the fluid that's running into your arm is either hyper or hypotonic, then it's going to burn like hell, and it's going to turn the vein really red, and the vein is going to fail, and you're going to have another IV started in another hand or in another spot, and that's really a pain if you're trying to take care of patients. So you always want to try to use isotonic IV fluids so they don't hurt and so they don't damage the inside of the vein that they're running into. So here's kind of a slide that summarizes this, and I'll just leave this for you. Just remember that 0.9% sodium chloride, which is 0.9% sodium chloride, which is normal saline, D5W, which is noted as D5W, which is 5% sugar, and the third one, is Ringer's lactate, which is, as we just discussed, it's also isotonic. And notice it has a pH of about 6.6. That's those are the 3 classics. You can see these others that are listed here have either more or less sugar, more or less electrolytes. But if you just go with those 3, you kind of understand all of them. Here's what a liter bag looks like. This is a 500 milliliter bag, and this is sodium chloride 0.9%. I think that says, but these old eyes won't tell me for sure. Pearls of wisdom, which I try to give you guys from time to time. In general, all you have to do is give the body the stuff it needs. The kidneys and the lungs will then figure out what it really wants to keep, and it'll really help sort out all of this fluid and electrolyte stuff. Now, obviously, you push it to the limits oftentimes, and people that have sicknesses or diseases of one type or another will run into problems with their fluids and electrolytes. But in general, if you just don't do anything stupid as a healthcare provider and you give the patient something, they can figure it all out on their own and keep themselves straight. The most common order that I used to always write for maintenance IV fluids in a patient who was NPO, nothing by mouth, but needed some IV fluids, was D5 half normal saline with 20 milliequivalents of KCl at 125 cc's an hour. Now you might wonder, why did you pick 125 cc's an hour sessions? Well, think about it. Nurses generally work on 8-hour shifts. Now they don't always, but most of the time, at least when I was doing this stuff, they worked 8-hour shifts. And if you're giving a bag of IV fluid at 125 cc's per hour, that just so happens to be 1 liter every 8 hours, which means that each shift of nursing staff is going to put up a bag of fluid, and then that bag should run throughout their shift. So that's pretty easy, and it's easy to take care of, and it's easy for the nurses to keep track of as well. They put a piece of tape down the side of the bag with the hours listed, and usually they can figure it all out, and it works out really well. You can figure out, like if you give them this fluid right here, that's going to give them 3,000 cc's of water, like I just said, or 1,000 per shift. 221 milliequivalents of sodium, which is not too abnormal. 281 milliequivalents of chloride, because remember they're getting the chloride from the KCl as well. They're getting 60 milliequivalents of K, which is really helpful to them, and 150 grams of sugar, which is only a grand total of 600 calories. So nobody's going to get fat on it, that's for sure. Anyway, I think that the inputs are pretty complicated here, are not very complicated. Usually they're pretty easy to keep track of, unless the patient is sneaking food or sneaking IV fluid or eating a ton of ice. And so nurses keep track of it shift by shift, and you know exactly what the patient's had in, and you know exactly what they've had out. Now, what are the sources of output? Because there's lots of them as well. And the first one that may come to you is just simply urine output, and that's easy to keep track of. Usually a patient can at least pee in a jar for you. If they can't, they probably have a Foley catheter in that's able to be caught and measured every time. So here's a patient with a Foley catheter in. The fluid comes out into this upper channel. The nurse can measure it every hour or 2 hours or 4 hours, whatever it is, however intense it is. And then they can pour it into that lower bag and keep track of how much they've made for the day. This is what a Foley catheter looks like. This is where the urine goes in. The urine goes in through these side holes up here, and it comes back down through the tube. It comes out the end here, and this is the part that you attach to the thing that's going to collect the urine. This is the little side arm here is just strictly for inflating this balloon. So you put a syringe on here, and every Foley is different. Most of them take 5 to 10 cc's of fluid or air, either one, and you inject that into here. It makes the balloon blow up, and then you disconnect the syringe, and there's a locking mechanism in this orange thing here that keeps the balloon inflated. And they can last for 2 weeks if you really need it for that long. Another source of output is the NG tube, the nasogastric tube. Nasogastric tubes are inserted through the nose, down the esophagus, and into the stomach. Notice the direction that this person is sticking it. It doesn't go up like you put your finger up your nose. It goes straight back into your head, because that's the direction that your nasal cavity goes, back into the nasopharynx, back into the oropharynx, and on down into the laryngopharynx, and on down into the esophagus. So I have to tell you that in my entire career, I never had a single patient who I couldn't put an NG tube in. Now, a lot of times, I didn't like to do them. I would always write for the nurse to put them in, and they got in 90% of them. But occasionally there would be one that they just couldn't do, and usually it was because the patient was coughing and gagging and all that jazz. And so I would come, and I could usually calm the patient down a little bit better, maybe. But I could also just simply explain to him the importance of this tube. Because in general, if someone's had surgery on their intestines anywhere downstream, it doesn't work for a while. So if you don't suck the juice out of their stomach, they're going to vomit it. And if they vomit it, that means they're going to retch. And that means they have the chance of tearing everything loose that you just sewed back together down there. So usually I would put the NG tubes in the freezer for a few minutes. That would make them really stiff. I would fill their nose up with lidocaine jelly, and I mean truly just squeeze a whole tube of lidocaine jelly into their nose, which would completely numb up their nose and all the way down to the back of their throat. They would feel it in the back of their throat, and I would just tell them to swallow it, and it would numb up their larynx as well. And then if you put the tube in at this direction right here, and then you get it back to about right here, and you say, okay, Mrs. Jones, get ready. I want you to swallow for me. And when they swallow, and you can watch their Adam's apple and know when they're swallowing, then you push the tube on in. And once you get it into the upper esophagus, it's no big deal. You just slide it on down, and down it goes. And you want it to go into the stomach. Then you hook it up to suction so it can suck out the juices, which basically just keeps them from vomiting. And it does, and even though nobody likes the thought of having a tube in their nose, after a few minutes, it doesn't bug them at all, and it keeps them from, like I said, getting sick and throwing up. Now there are problems that happen with NG tubes, and I never saw one, but this is an interesting X-ray. This is a patient who had an NG tube placed. This is a CAT scan of their brain. You notice there's a bubble of air up here. You notice there's another bubble of air here, and this is the NG tube right here, and this is another piece of the NG tube coming through the slice right there. So what happened in this case, and I think this was a kid, the NG tube was inserted, instead of down into their esophagus, it was inserted up into their brain. It coiled. It let some air into their brain, and that's not a good deal. I wouldn't want to be the lawyer involved in that case, or the physician, or anybody else involved. That's kind of what can happen. That's very rare. I know, like I said, I never saw it or even heard of a case, but that's a pretty neat x-ray. NG output. What happens if you put this tube down into their stomach and you notice that it's putting out literally tons of fluid? I mean, like a liter every shift. And you notice, you look at it and it's dark green like that. Well, where do you think you've got the NG tube? Well, you've got it too far. It's gone out of the stomach and it's gone down into the duodenum. And when it's in the duodenum, obviously it's getting direct flow from the bile. This is pure bile. It's, gosh dog it, quit doing that. It's got pure bile in there, and all you have to do, I mean, it's not a serious problem sucking their bile out, but when you suck their bile out, that's sucking out another 2 liters a day, which means you got to replace all that stuff. So what you'd rather do is just pull the NG tube back 3 or 4 inches, and usually then it'll be back up in the stomach. It won't be so dark green. If it's green at all, it'll just be stomach contents, and it'll do what you want it to do without being down so far. You don't have to do an x-ray to verify that. Just pull it back a few inches, retape it, and you'll find everything is cool. A lot of the output that we get in patients is from either blood that was sucked out in the sucker at surgery, or from sponges. One of the jobs of the operating room nurses is to take the bloody sponges that come off of the operating table and lay them out on a piece of plastic in groups of 10. And you put 10 sponges out there and you open them up, and then the anesthesiologist looks at them and says, yeah, okay, that looks like about 40 cc's or 60 cc's or whatever. And he writes it down in his record because it's his job to take care of the blood loss, the EBL, the estimated blood loss during surgery. So that's kind of cool. And, you know, we always figure that one sponge that is totally full of blood, that's just dripping with blood, is about 10 cc's. So that's how you just kind of figure from there and come up with a number. Little drains, we leave all kinds of drains in things that suck out fluid, and that can be measured exactly as well. This is called the Jackson Pratt drain. I used to work with Dr. Pratt. He was the weirdest neurosurgeon I ever met in the Navy. He had developed this when he was at Stanford, I think, and really smart guy, but boy. Anyway, these are little, you squeeze these down and they apply gentle suction, and the fluid comes out through all these little holes and comes up here and collects in this bulb. That's it. Fever is another thing you got to keep track of, because if somebody has a really high fever, then they are not only sweating more, but they also are losing more fluid in their breathing. And that's just additional fluid loss that you kind of got to keep track of. And if they got really high fevers, you just have to give them more fluid to keep up with that. Here's kind of a list of all the different outputs that occur. Urine, stool is not much of a problem unless somebody's got really bad diarrhea. If someone has cholera, they can poop out 5 liters a day of stool. That's what kills people with cholera, for example. It's just this massive clear diarrhea that they get. Vomiting can be measured. Ostomy output. If someone has an ileostomy where their ileum has been brought out to their skin and hooked up to a bag, it can be huge, but you can measure it as well. All these tubes can drain all kinds of things. Bandages have to be examined and figure out about how much blood came out on the bandages. One of the hugest fluid and electrolyte problems in medicine is patients with severe burns, because burns weep so much fluid. They basically have no skin left, so the fluid just weeps out, and it all has to be replaced. It's all evaporating off and so forth. I've seen babies get into trouble just because people were ordering too many blood tests on them. And every time they used to come and draw 10 cc's or 15 cc's of blood for blood tests, that was a lot of blood for a baby. Now, in modern hospitals, it only takes a drop or two to do most blood tests. So that problem has kind of been overcome. Estimated blood loss, if somebody went to surgery, then they have an EBL that's always recorded on the chart as to how much fluid they lost in the operating room. Insensible losses like breathing and fever increase your fluid loss, and so you kind of got to keep an eye on that as well. Let's talk about the electrolytes for just a minute. I know we talked about them the other day, but the big six are sodium chloride, bicarbonate, potassium, BUN, and glucose. Now, BUN is blood urea nitrogen. Glucose is sugar, just like you've always known. Sodium Na is normally about 140, chloride's about 100, bicarb's about 24, and potassium is about 4. So keep those numbers in mind as we go through this. In fact, I just made a nice little list for you right there. Normal BUN's about 20. In somebody that's in renal failure and their kidneys aren't working well, or they're severely dehydrated, the BUN can go up to around 100. Once it gets to 70 or 80 or 90, then you're talking about dialysis. So that's something to keep in mind. Let's talk about body water for just a minute. I know we talked about it the other day, but body water is either in the cells or it's outside of the cells. It's either intracellular or it's extracellular. Most of our fluid in our body is intracellular. The extracellular fluid is basically in two major components. One is plasma, in other words, the upper part of blood after you spin it down, and then interstitial fluid, which is the fluid that's out between the cells. Which one are we able to evaluate? And that's an important thing. This was a concept that I don't think I understood till I was like a chief resident. We can never, ever know what the electrolytes are of intracellular fluid. Now, wait a minute. When you read your book, it tells you what normal intracellular sodium is. It tells you what normal intracellular potassium is and all that jazz. And they're very different than extracellular fluid. The reason that we in medicine never see these numbers for intracellular fluid again is because these were determined by significant research that involved basically sticking a micropipette into a bunch of cells, drawing the fluid out of the cells, and then analyzing for the level of electrolytes in those cells. Well, that's all fine and good, but in clinical medicine, in the hospital or in the clinic or something, you'll never see a value for intracellular fluid ever again. The only numbers you will ever see are for extracellular fluid. The reason is that all blood tests done in clinical medicine are done on the plasma. In other words, you take a tube of blood from the patient, you spin it down, and that plasma is what you insert into the analysis machine that comes up with a number. Now, since we can only evaluate the extracellular fluid, how does it work? Well, I mean, because we don't really know what's in the intracellular. Well, you do in a way, because if you know what the extracellular fluid levels are of all these different electrolytes, you can figure the intracellular levels are pretty close to that, or at least they're equivalent, so that if extracellular fluid values are normal, you can figure that intracellular fluid values are probably pretty normal as well. But just so you know, and I think that's something that was hard for me to catch at first, is that you will never see another value for intracellular fluid. Let's do some cases. I hope these will be illustrative for you. You may find one of these on the fluid and electrolyte question that's on your essays on the exam next week. Case 1, 23-year-old guy. He's a healthy appearing guy, but he's thrashing about. He's not answering any questions appropriately. You can't really talk to him. He was brought in from a car accident. He's in obvious pain, terrible pain. He's got bruises all over his chest. He was not ejected from the car. He was restrained, and what that means is he had his seatbelt on. He was the driver of the car, and his airbag was deployed. Well, let me tell you that when somebody is the driver, that creates a set of injuries that the passenger doesn't have. The driver has a steering wheel in front of him. He also has an airbag. Now, passengers these days have airbags as well, but that's all important information. Now, the fact that he was not ejected is very key, because if you get thrown out of your car in an accident, you have a 7 times greater chance of dying. If there's ever a reason to wear a seatbelt, both a lap belt and a chest belt, that's it. You don't ever want to be thrown outside of your car, because your car is so protective of you. He was talking at the scene, and he was talking in the ambulance, the paramedics told you, but now he's not really answering any questions. He's really out of it. So he's obviously getting worse in the minutes that it's taken him to get to the hospital. So now we got to figure out what's wrong with him. So here we go. We get some blood work. His hematocrit is 38. What's normal hematocrit? 45. So he's either lost a bunch of blood. Well, he has lost a bunch of blood. Usually your hematocrit falls about 3 points for every unit of blood that you use. So I would say he's lost over 2 units of blood, from 48 down to 38. His blood gases don't look very normal. pH is 7.15. What's normal? Well, 7.40. And so he's very acidotic. He has a PO2 of 55. What's normal PO2? Pretty close to 100, 90 to 100. And so he's not getting enough oxygen, but he's getting some. He's not going to die at 55. His PCO2 is 58. What does that tell you? Well, what should his PCO2 be? Well, it should be about 40. And when it's 58, that means he's not breathing enough. He's not moving enough air in and out. He is not ventilating enough. So for some reason, he is not moving enough air in and out of his system. His bicarb is 24. Well, that's normal. But guess what? It takes a while for your bicarb level to change. His O2 saturation rate is 75, which obviously isn't normal. Chest x-ray is pending. Electrolytes are normal. In other words, his sodium, potassium chloride are all normal. But remember, he has lost blood. And his EKG shows a sinus tachycardia. What's that mean? Well, sinus tachycardia means that his pacemaker is normal. It's his sinoatrial node that's pacing his heart. But it's tachycardic. It's very fast. And it shows an anterior injury pattern. What does that mean? Well, that means the front of his heart has taken a hell of a beating. And in any patient that hits the dashboard, or even is hit by an airbag, it's like boom. Your heart gets smashed into the inside of your sternum, and your heart gets bruised. Now, having your heart bruised is not quite the same as that area of your heart dying from a heart attack, but it looks pretty much the same on EKG. So you've got a bruised heart, and indeed a lot of trauma patients will actually die of heart failure because of injury to the front of their heart. Now, when I say anterior injury, that just means that we can look at the chest leads on the EKG and say that, yeah, the injury is in the anterior part of the chest. But hey, surprise, surprise, this guy was in an accident, a head-on collision of some type. His airbag went off, he took a beating, and his heart took a beating as well. So, you always need to go back to this chart right here, and let's just work our way through it. First of all, he has acidosis, right? His pH is less than 7.35. It's quite a bit less than 7.35. So you can ignore this side of the chart over here. Now, what happens to his PCO2? Well, is his PCO2 increased or not increased? Well, clearly his PCO2 is quite a bit increased. So therefore, the cause of his acidosis is a respiratory acidosis. It is caused by hypoventilation. He is not moving enough air in and out of his chest in order to maintain his pH being normal. So knowing that, the next thing to check is his bicarb level. And his bicarb level was normal. And since it was normal, you know that he has acute respiratory acidosis. Now, examples of that would be respiratory failure for some reason, CNS damage. Usually if you've damaged your brain and you don't breathe enough, that can cause acute respiratory acidosis as well. And pneumothorax is the third choice here. Well, this is his chest x-ray, and this guy would probably be dead if you waited for this chest x-ray to be done. Because we were always told that if you took an x-ray like this, you were an idiot. Because you should have been able to look at this patient and figure out what he needed, and what he needs is a chest tube on this side. He has acute tension pneumothorax. Notice that his lung is compressed to right here. Notice he has a bunch of fractured ribs. Notice he has a bunch of subcutaneous air. This is air that is leaked out into his fat and is outlining his ribs on the outside up here. Notice that he has shifted his mediastinum. His heart is pushed over to the right side. And yes, this is the right side. Notice that he has an endotracheal tube in already. Notice that his trachea is bent over to the right. You should be able to feel his neck and know that his trachea is deviated to that side. And what this guy needs within the next minute or two is a chest tube in this side. You put a chest tube in over here somewhere and suck all this air out. That allows the heart to move back over to where it's supposed to be. Therefore, his superior vena cava, his inferior vena cava are no longer going to kink off. He's going to be able to get the blood back to his heart, and he's probably going to perk up quite a lot. They've obviously already got a tracheal tube in him. Here's an endotracheal tube. Notice that it comes down to right about there, it looks to me like. It probably ought to be down to about here. You usually want them about 2 centimeters above the carina. Obviously, with everything distorted like it is in this picture, you can't really say, but the next x-ray would be taken 5 minutes later and show lots of changes. So, this guy was really short of breath, he was in lots of pain, and he was dying. His blood pressure was probably down to about 50 over 30 because he couldn't get the blood back to his heart, and this is an absolute acute medical and surgical emergency. Tension pneumothorax is the diagnosis, and the physical exam, you would have heard some lung sounds on this side, but you wouldn't have heard any lung sounds on this side. You would feel these ribs. It's just like crunchy over here from all these pieces of rib that are broken in there. You would feel these little bubbles of air in his subcutaneous tissue. And like I said, if we ever took an x-ray like this in my training program, you were going to have to explain why you didn't figure it out, what was wrong with the guy before you had the x-ray, because an x-ray like this will take 15 minutes or so, and patients can die in 15 minutes of this problem. So here's what he looks like later. His heart's come back to normal. He's still got some problems over here on this side, but it's getting better. And he's going to make a good recovery from that. Here's an example, a schematic of a pneumothorax. This is on the other side. Notice that the heart should still be right in the middle, and with a regular pneumothorax, that's the case. There is air out to here. You can usually see this line, the edge of the lung coming down like that. But when it becomes a tension pneumothorax, and this is another just regular pneumothorax you see here, lung is in about an inch or so. The heart is not really much shifted, and so forth. This is what an anterior injury looks like. Here's the, this is lead 1, 2, and 3. This is lead 2. This is the one you're used to looking at, and it looks pretty normal. But if you look over here in lead V1, V2, V3, V4, V5, V6, notice that he has a QRS, and then it stays up here, and it never comes down. And then his T wave, this is his T wave, and it finally comes down. This is what's called ST wave elevation. It never comes down at all. That's a sign of acute injury to this part of the heart. And over here you see even out here in 5 and 6, the ST wave never comes back down to normal. Obviously, this is not an EKG course, but I just want to show you that EKGs tell us so much, and it's so quick because you can get the information back almost instantaneously. So if you're going to put a chest tube in, where do you put it? Well, you want to go, you usually make the incision kind of between two ribs, spread a little bit, and then do you want to put it above or below a rib? Now think about it from your A and P. Do you want to put it above or below? I hope you answered above. And this is an example right here. Here's the hemostat going right above the rib and then poking into the air cavity here to put the tube in. Now, the reason you don't want to ever go below the rib is because that's where the arteries, the veins, and the nerve run. Remember that from your anatomy of the ribs earlier on. So you always want to go, you want to feel in here for the rib, you poke on the rib, it's feeling, you're pushing on bone, and then you just kind of walk up to the top edge of it and then stick in and put your tube in. Here's a chest tube going in, and I'll just leave it at that. It's hooked up to a pleurovac, which not only maintains suction, but then collects any blood and stuff that happens to come out. Once again, you can keep track of the I&O. All right. Case 2. Patient comes into the emergency room, says he's feeling a little bit more short of breath than usual. He's always short of breath. And his family says, you know, he's been getting really sleepy. And they're worried that he's about to die. Here's what he looks like. This is kind of the chest of a normal chronic lunger. This guy's probably got 110 years of or more of cigarette smoking. That's a pack a day for a year. It's 1 pack a year. So he may have had, 3 packs a day for 30 years. That'll give you 90 pack years. This guy looks like he's had more than that. Notice his accessory muscles of respiration, his sternocleidomastoid, his scalenes. All of those muscles are pulling like hell, trying to help him breathe more. This is not a guy running a marathon. This is a guy just trying to breathe enough to stay alive. This is an example of the barrel chest that patients with chronic lung disease get. Here's an x-ray of a patient with chronic lung disease like this guy could have. Notice there's not all that much in the way of lung markings out here, but there are some, so he doesn't have a pneumothorax. Notice that his chest is completely full of air. His diaphragm, which probably should be about up at this level, is pushed down to here, and it's pretty flattened. That's because his lung is expanding, trying to get as much air in as possible. He's got 150 pack years of smoking, and what do you expect to find on his blood gases and electrolytes? Now think about it. What do you think his blood gases are going to look like? Well, this is a guy who is not able to breathe well enough, but he hasn't been able to breathe for years. So that's kind of a problem. And if you can't breathe enough, we know that you're going to build up your CO2. And indeed, this is what his blood gases look like. Now look at these for just a minute and think about it. First of all, he is very acidotic. Okay? Now why is he acidotic? Well, he's acidotic because he can't blow off his CO2. His CO2, which should be 40, is up to 56. And that's almost enough to account for the 7.19. In general, for every point the PCO2 goes up, the pH should go down 0.01. Pretty close to that. That was a rule I always used, and it worked pretty good. His PO2 on room air is only 54. Now, that's not good. Obviously, it should be between 90 and 100. He is not getting enough oxygen. You're looking at him and he's trying to breathe like hell, and he is breathing like hell, but he's obviously not moving enough air. At least he's not getting enough down to his alveoli, at least functional alveoli. So his PCO2 is elevated up to 56. Bicarb is about normal. His kidneys can maintain his bicarb and keep that about right. His O2 saturation is down to 83. So this guy has an obvious case of what's called chronic respiratory acidosis. These old geezers like this, who are always on oxygen, you see the little tube here coming up to his nose, getting oxygen. Their lungs look like this. This is big pieces of um, chronic bronchitis and emphysema. This is emphysema. Notice that a lot of the alveolar walls have been damaged, and he's got these big holes in his lung. He's breathing in and out, but it's just not doing him any good. This is an example of a guy who's even worse, because obviously he's died. This is his lung almost full of blood and stuff in his lungs. Not a good thing to have. I miss my lung, Bob. I noticed that our new vice president, or our next vice president, was a strong supporter of the cigarette industry, and up until the late 1970s, he still thought that lung cancer was not caused by cigarette smoking, even though the Surgeon General had come out and said that in the early 60s. But he was getting enough money from the tobacco industry to continue to push for it. This is what these guys look like. You put them in the hospital. It's really important to never, never, never intubate one of them, because intubation will help them in the very short term, but these patients will often never get off of a ventilator. So yeah, it can help them for a while, but the fact is you simply have to be able to breathe on your own. And you see them holding up this "do not smoke" sign. Everybody figures it out at the end of their life. It's always sad that they didn't figure it out 20 years earlier. Okay, so that's respiratory acidosis due to chronic lung disease. Pretty common thing we see these days. Case 3, middle-aged man with a long history of ulcer disease. Now, ulcer disease obviously is a disease of the stomach and of the duodenum. He comes in today with a CC. CC means chief complaint. I always hated to use those words because patients don't really complain. They're not complaining. They're just stating their symptoms. And so his symptoms are that he's been vomiting a lot. He's really weak. Hasn't made any urine since yesterday. What would you ask him? Well, you know he's got this history of ulcer disease. And so ulcers bleed. That's one thing they do. You might ask him what his vomit looks like. How many times has he vomited? Is there any blood in it? Well, he vomits about twice a day. He's been vomiting twice a day for a week and a half. What does his vomit look like? It looks pretty much like the food he just ate. In other words, if he ate a hamburger, it sort of looks like mushed up hamburger coming back up. It is not blood. There is no blood in it. It is not dark black, which would indicate blood that had been in the stomach for a while. When was the last time he urinated? He said it had been since yesterday. What color was it? You can bet if he's been vomiting everything up and not getting any fluid in, it's going to be really dark yellow. Does he take any medicines? Obviously, medicines can cause vomiting. They can cause all kinds of problems. So what blood would you order? Well, anybody that's been vomiting, you got to really worry is in fluid and electrolyte problem. Sure enough, here's what his blood gases look like. His pH is 7.64. What does that mean? Well, that means he's obviously severely alkalotic. His PO2 is okay, so he's breathing okay, and his PCO2 is 40. So he's breathing just fine. He is not in respiratory alkalosis because his PCO2 is normal. He's getting enough oxygen, so his lungs are probably working pretty good. What are his electrolytes? Well, here's where the problem is. Sodium is 128. Now, normal is 140. So he has lost a ton of sodium. And indeed, when you vomit repeatedly, you lose a ton of sodium. His chloride is 78. That's really low. It should be up at 100. So he's lost both sodium and chloride. And let me tell you, when you vomit salt. Um, you also vomit acid, because hydrochloric acid is in your stomach, right? So his bicarb is up to, excuse me for that, his bicarb is up to 40. And his potassium is super low at 2.8. And remember, I think I mentioned to you before, when your potassium is low like that, that can mean you are literally thousands of milliequivalents of potassium behind. Because remember, potassium is mostly an intracellular electrolyte. Normal intracellular potassium is up between 70 and 100, whereas extracellularly it's really low, normally about 4. But remember, we can only analyze for that extracellular potassium. So he's super behind in potassium. He is very alkalotic, and he's way behind in sodium and chloride, all from vomiting. He has a metabolic alkalosis. It's not respiratory, it's purely metabolic, because his PCO2 is normal. In fact, we would call this a hypokalemic, in other words, low potassium, hypochloremic, really low on chloride, alkalosis. Here's what his belly film looks like. Now, what's this right here? Well, the key to this x-ray is this little signal right here, because the arrow always points up. So what that means is this film was taken with this patient in the right lateral decubitus position. In other words, left side down, right side up. In other words, this is the way you should be looking at the film. Arrow pointing up, air fluid level, air above, fluid below. Okay? A little bit later, you get an upper GI x-ray. You give him some barium to swallow, and the barium goes down into his stomach, but it really can hardly get out of his stomach. This is his duodenum, which is scarred and long and really blocked off. Right there. You can see a little bit getting through into his duodenum over here. This is an x-ray of the same person. And this is a CAT scan. Gosh, dog it. This is a huge stomach, and it seems hard to believe that a stomach can get this big. But as a stomach stretches, it stretches very slowly, and then these people start vomiting. They usually don't vomit and really empty their stomach. They just vomit a little bit, the last food they ate, and this just progresses on and on and on. I've never seen a stomach that big, but I've seen several that were pretty close to that big. So, what do you do to treat this? Well, he's probably going to need surgery to open up his duodenum, but first of all, he needs an NG tube, and you need to suck all of this stuff out of his stomach so he doesn't vomit it and so he doesn't aspirate it. So you suck it all out. That'll make his stomach come down to normal size. You treat him with anti-acid medications like Pepcid or Zantac, and then you reevaluate him here in a week or so. In the meantime, you give him lots of water, you give him lots of sodium, you give him lots of chloride, and you give him a ton of potassium to make his electrolytes come back to normal. Then you'll probably have to do surgery to create a new opening between his stomach and his duodenum, so that food can get out of his stomach in the future. When a stomach has been stretched this big, though, you just have to give it about a week to regain its tone and start working properly again, even if the obstruction is repaired. So you generally wait on these a while. Okay, let's go back. Let's do case 4 here. In case 4, you have a sick patient who's up in the ICU. He's been doing better over the last few days. Been recovering from a car accident and intention pneumothorax. Well, maybe it's that same guy that was in case 1. But he's now 3 weeks post-op, and he's about ready to get off the ventilator. He still has his endotracheal tube in, and the respiratory therapist gives you an arterial blood gas report and says, what do I do? Well, I think one thing that you have to learn in medicine that's so critical is that you always have to think straight, and you have to organize the data that you need in a constructive manner. You don't go jump into conclusions. So the first thing I would ask is, well, why did you do the blood gas? Because it's not normal to just do blood gases willy-nilly, although patients that are on ventilators always get at least one blood gas a day, if not more, just to make sure everything is okay, make sure the ventilator's working right and so forth. So I might go examine the patient. I also might look at the most recent x-ray and make sure there's no problem there, listen to both sides of the chest, make sure make sure on the latest x-ray that the endotracheal tube is coming down to the right spot. Make sure it hasn't gone all the way down into the right main stem bronchus, because when an endotracheal tube gets put in too far, it always goes down into the right main stem bronchus. And you get a full report from the nurse. What's the patient's vital signs? How's he doing? How does he look? And here's the blood gas report that you get. His pH is 7.62. So is he acidotic or is he alkalotic? Clearly he is alkalotic. What's his PO2? It's 87. That's pretty normal. What's his PCO2? His PCO2 is 19. What should it be? Should be about 40. So he's blowing off a lot more CO2 than he should be blowing off. And if you blow off too much CO2, you become alkalotic, right? What's his bicarb? It's still pretty normal. The rest of his electrolytes are normal. His glucose is normal. His BUN is normal. So it looks like he only has one real big problem, and that's his PCO2. His PCO2 is really low. He is breathing too much. But wait a minute. He's on a ventilator. So that means the ventilator is breathing him too much. He has respiratory alkalosis. It's pure respiratory alkalosis. In this case, it's clearly a ventilator problem. Somebody has bumped the dial and maybe turned it from 12 breaths a minute up to 18 breaths a minute or something like that. And you fix it by just adjusting the ventilator. Easy fix. Metabolic acidosis. Let's talk about it for a second. How does somebody get really acidotic? Well, let's talk about a kid with diarrhea. Kids with diarrhea will get really acidotic as they lose all of their electrolytes. You can oftentimes diagnose this. They might have a sunken fontanelle in front if it's a really small baby before they have sealed off their fontanelle. They're dehydrated. They're fussy. Kids, whenever they're sick, it doesn't really matter what's wrong with them. They're always fussy. They simply just can't be bubbly, happy, and laughing. So you would check their electrolytes, check their urine output, and I think I'll just leave that one at that. Case 5. You're working in the emergency room, but a nurse calls you from up in the ICU, and she's really worried about a patient she's been taking care of for the last 8 hours. She just measured the patient's urine output and noticed that it had really picked up. In fact, it was 1,500 cc's for the previous shift. Wait a minute. 1,500 cc's of urine in 8 hours? That's a hell of a lot. And now she just measured, and the urine output for her shift is 2,900 cc's in the last 8 hours. So this patient is pouring out urine. Why? Why would a patient be pouring out that much urine for no apparent reason? Well, clearly if they'd received way too much fluid, that could account for it. But this patient's in the hospital and all that's been monitored. Patient is 3 days. SP means status post craniotomy. In other words, they're 3 days after a craniotomy, which is an operation on their brain. It was done for a circle of Willis aneurysm clipping. They had a baryaneurysm of the circle of Willis, which is the area of communication between the vertebral arteries coming up from the back of your brain and the common carotid and internal carotid arteries coming up from the front. and they had a big aneurysm on that, and the doctors went in and clipped off that aneurysm so it doesn't bust and bleed into their brain. Patient didn't have any problems with the surgery. Patient is awake, he's alert, and says, I don't ever remember making so much urine. So here's an example of a berry aneurysm. It's named Berry because it looks like a berry. It wasn't named after Dr. Berry. It was simply looks like a berry. And the way you fix these, you go in here and put a little clip right across the base, and then it just kind of dissolves away and goes away. And it doesn't keep getting bigger. If you leave it there and it keeps getting bigger and bigger, it's going to bust, and that's a tragedy for the patient. The patients usually always either have a very, very severe stroke or they simply die. Here's an example illustration of a clip being placed across an aneurysm. That's obviously not in the patient anymore. Probably just a berry aneurysm that was found on an autopsy. So the nurse says the urine looks like pure water. She did a dipstick on it. There's no blood. There's no white blood cells. There's no nitrates. There's no glucose. In fact, everything on the dipstick was negative. The specific gravity is 1.001. The electrolytes on this patient were normal this morning. 20 hours ago, electrolytes were normal. So what do you think may be going on here? What would make a patient make that much urine after a craniotomy? Well, here's the new labs. Potassium is 4, that's normal. Sodium is 158, that's up. Should be about 140, right? So if you've gone from 140 up to 158, you've either gained a lot of sodium to make it that high, or you've lost a lot of water and you become a lot more concentrated, right? Chloride is up quite a bit too. It's up from 100 to 116. Bicarb is pretty normal at 28. Serum osmolarity is 330. Is that normal? No. What's your normal serum osmolarity? 300. So this patient is becoming very, very hyperosmolar. That's quite a bit up, 330. On the other hand, if your serum osmolarity was really high, you would want to be peeing out urine that was really high in order to help correct it. But this patient has a urine osmolality or osmolarity of 15. So the urine is not responding appropriately, and maybe that's indeed what the problem is. What's going on here? I'll bet a third of you know the right answer. This is caused by injury to the hypophysis, the infundibulum of the pituitary gland during the surgery, and the hypophysis has been injured, and as a result it is not releasing ADH. Remember, ADH is made from the posterior hypothalamus, and this patient has diabetes insipidus, which is caused by a lack of ADH. How do we treat that? Well, in the old days, you just had to treat them with more IV fluid to try to catch up with how much they were losing. But these days, they've been able to synthesize antidiuretic hormone, which is a nasal spray. They give the patient a little ADH, and this all corrects itself. He suddenly starts making more concentrated urine because he has ADH, and everything corrects itself in about 2 days. Usually, these patients recover quickly. Usually, this was just a bruise of their hypothalamus, and after about 6 weeks, this patient doesn't need any more nose drops, and his infundibulum is recovered. Let's talk about salt for just a minute. Salt is what makes food taste great. I'm terrible about using salt. I use way too much. Here's an old ad off of Morton Salt. It says, help keep your family goiter free. Now, why would salt make you goiter free? Well, remember that the thyroid needs iodine. And so the federal government figured that all out, and the doctors figured it all out, back in the 20s and 30s. And so the United States started requiring that iodine be added to salt. And it's a tiny, tiny, tiny amount. but yet that's enough for people who don't get any iodine in their regular diet to do just fine. So it literally ended the scourge of goiters in this country. And goiters used to be a massive problem. These ladies with these huge swollen necks, men as well, and a lot of them died having surgery. I think I've talked to you about the problems with goiter surgery. So that's one thing that we've really done right. Another place to think about salt is when you go out to eat, because our normal salt requirement is about 2 to 2.5 grams a day. In other words, 2,000 to 2,500 milligrams per day. And if you look at a Big Mac, this is one Big Mac, and I never eat one, I always have two. Notice that in each Big Mac there's about 1,010 milligrams of salt, of sodium. Indeed, a single Big Mac has 42% of all the sodium you need for that day. So if you eat two of them, that's 84% of all the salt you need. Now, I will tell you that if you have an order of French fries with this, you're going to be up to about 4 grams of salt just eating two Big Macs and an order of fries, and you're going to have way too much salt in. It's going to run your blood pressure up, and it's going to kill you in the end. So always kind of pay attention to this. Sodium level is very important. I love this sign. Your wife is fat. You are fat. Your kids are fat. Welcome to America. Way to go to McDonald's. Way to go, McDonald's. Just a few things to think about. Hope that helps put it all together a little bit for you. If you have any questions, give me a holler.